All right, we're live, guys. This is our first episode of a podcast called Home Care Coach's Corner. And today we're going to talk about the rise of home care and healthcare in the healthcare continuum. Are you guys ready?
We are
ready.
So you all know me. I know you guys. We've been working together for a long time, a lot of experience. We're great. I always got to break the ice a little bit with a little joke. So I'm going to tell you guys this. What do you call a sheep that can sing and dance? Lady Baba. All right, here we go. You guys ready for that? All right. Next. Wah, wah. All right. So today we want to talk about this podcast. Let's first go into here. I'm going to host it and I want to ask you guys questions. And you're going to do most of the talking. I'm going to do most of the listening. That's really hard for me to do usually. So I'm really excited about it. But this Coach's Corner, I want to give a brief rundown of what it's going to be for. And we're going to do multiple episodes. We have coaches here. We have Tiffany Dutcher, who has 8 years of home care franchise ownership experience. Tiffany, what franchise did you own? Where do you come from? And how did you grow your business? And what was the highest peak you ever got to? Let's get your experience here on the record. Ready? Go.
So I'm Dallas-based. I owned a BrightStar, which did both skilled and non-skilled. So I do have experience not just focusing on private non-skilled care, which I think kind of feeds into our topic today, which is expanding your business beyond private pay. I did grow my franchise when I first started. They were doing about 10,000 in billing a week. It's kind of hard for me to translate it into hours because we did both skilled and non-skilled, but by the end I was billing about $100,000 a week. It was a really fun business. I enjoyed it so much. I ended up in a coaching seat here at a place at home. In between, I also coached for Nurse Next Door, which is a similar franchise model. And that's why I'm here today.
Awesome. Yeah, we're glad to have you. And then we have Jennifer Axelrod from the land above, the sweet country of Canada, maple syrups and weird hats. Nice to see you, Jennifer. Why don't you give us a quick rundown? Rundown. You've been here the longest, so you're used to it.
I have. I'm used to you, Dustin.
Yeah.
Okay. So most people know I have over 13 plus years experience in franchising, working with a skill set of so many hats. But my real house is marketing and sales and franchise relations with franchisees and helping them grow successful businesses. Yes, I'm new to home care, but now I'm in year 2. So this is the year is organization, where we tell our owners first year's chaos. It definitely was chaos, but it was exhilarating. It was meaningful, impactful, and I'm so excited for what's to come.
Awesome. Thank you, Jennifer. And then we have Shane from Florida, the swampland, who has 7 years of home care experience being ownership in a franchise out of Florida. Shane, what franchise were you with? And what's your background? And what was some of the successes you had as a franchise owner?
Well, I came on with Home Instead, and we owned a franchise up in Savannah, and then partnered up, and we expanded into Florida, Jacksonville, St. Augustine, and Palm Coast, and 2 up in Ohio. So we had a total of 7 franchises and 6 franchises, excuse me. And our peak was around $15 million a year within working in those 4 states. So great opportunity, great team. Love the home care space, got into it because of my dad, and love working with owners now with the place at home.
Awesome. And then my experience real quick, 12 years, co-founder of A Place at Home. My role now is active as the CEO of A Place at Home. And I get the opportunity to lead these fine young ladies and gentlemen on this call here. And, you know, we wanted to do this Coach's Corner because of the experience. We have almost 3 decades. We need 2 more years. And, hey, Jennifer, you have 1 year of experience. You do have a year of home care experience. And that's really all you need to know home care and the chaos that goes with it. But today's conversation is the rise of home care over the last 12 years. So I want to set the stage, and Shane and Tiffany, you in particularly can kind of go with this. 12 years ago, I remember going out marketing, and I would get feedback from referral sources, social workers, discharge planners. And home care wasn't really taken seriously. We were a sitter, right? Oh, you mean sitter services? Oh, companionship, non-medical, not home health, right? You're not in home. You're not in the healthcare. You're private pay. Why? No one can afford you, et cetera, et cetera. My mindset is now healthcare, and correct me if I'm wrong. I want to open up to your guys' opinion, and we're going to talk about this. My opinion right now is healthcare can't afford not to have home care. So how do you guys feel about that, Tiffany and Shane, and Jennifer too? But going back to your guys' roots where you started, how far has it come?
I think our industry kind of did it to themselves in the beginning, like you said, positioning ourselves just as sitters, activities of daily living, but not really immersing ourselves in the continuity of care and making sure that we were partnering with like the home health, the hospice, making sure that we were discharging with the rehabs in a way that made sense, that kept the client safe. So I think it has evolved. Now, I came from a unique perspective because I did skilled and non-skilled. I did have that director of nursing that kind of directed me and opened up my eyes as to how we fit in better and can kind of pull in that clinical side to the non-clinical side. So I think you hit it right on the head. I mean, we are in a position now to really make our mark further than just sitter services.
Yeah, you look back when really a lot of them that were emerging on the scene, you think of how, the Homestead, the 800-pound gorilla that came into the marketplace, and no one really took them serious. They were really a sitter agency, private pay, to Tiffany's point. I think a lot of people in that sphere at that time really set up for failure because they only did one aspect of the business and didn't really look to broaden it beyond the private pay industry. Even when I came in as an owner, bought the business out, the existing owner was strictly just in that home care space of providing sitter services. So once you look outside of that, that's where this the home care can really become now an instrument of an asset to so many, from hospitals, rehabs. We become the viable source now for them.
And I think it's re-educating those referral sources, painting a picture of this is how you used to, envision our role, but this is what it should be and how we can become a major player with you guys.
Yes.
Well, I think it goes even further back, how people dealt with seniors and in families. And families were all together and they took care of their seniors. They took care of their family. And now we know that they go from state to state. So we are not just viable partners. We are a necessity, in my opinion, with all referral sources, because we know that the skilled side is not 24/7. It is not even 3 times a week sometimes. Sometimes it's 2 times a week. Sometimes they have wait lists. So there are other needs that can be met when it comes to taking care of seniors, whether it's a discharge from a hospital, rehab, or SNF, but also just to help out and provide some extra care in the home so that the family caregiver can get a break and get some respite.
Well, and I think a hot term right now is readmissions, and a lot of home care agencies are jumping on that. How can we help with readmissions? But I think we take it a step further, and how do we become preventative? So we're not just helping with the readmissions, we're catching it before that.
Absolutely. I'm glad you brought that up. Sorry, Jennifer, real quick. And I think that's when the turning point happened. Mm-hmm. A lot of people don't know this, but rehabs, hospitals, home health, they all got put into, they're all in part of CMS, right? And CMS did a research years ago. I can't remember exactly. I'd say probably 7-8 years ago. They started looking at patient outcomes, patient satisfaction. They even get discharged on how they deliver service, not just the impacts they have, how they deliver it. And ultimately, long story short, back then and even today, they get a penalty. If they're above a readmission threshold, they get a penalty, right? So all of a sudden, home care becomes that readmission blocker, right? We have, because what's the continuum, right? We're talking about the healthcare continuum. You have an episode. You're at home. Most people may use home care as a deterrent or as a preventative service, right? But let's be honest, a good majority of our clients, correct me and add to this, you guys, is those that are living at home alone, and all of a sudden an episode happens. They waited too long. They didn't want anyone in their house. And then they have a fall, they have a stroke, they break a hip, they go into the hospital. And then once you get into that hospital, that journey back to home could be anywhere from 8 days to 120, 140 days, as long as the rehabs are starting to get them better. And then they go home with home health services. But home health services are only there once or twice a week, giving a bath maybe as they continue to rehab at home. But other than that, it's dependent upon the family. With these readmissions that started coming down, they had to say, we need resources. And that's when, for me personally, my opinion is that's when home care started getting taken seriously. Like, guys, these are services that need to be in the home to prevent these unnecessary hospitalizations, which in turn, which we're going to talk about here on the second half of this, has turned into the VA looking at it and adding reasonable rates for us to provide services anywhere between 9. I've seen 30 hours a week of care to VA through their VA benefits through the healthcare system. Aid and attendance for coming out of the Veterans Benefit Plan, which is different. You have the Veterans Health Administration, think insurance. And then you have the VBA, the Veterans Benefit Administration. There's an aid and attendance. I give a couple $1,000s a month for for a veteran to utilize for care services, and not only for the veterans, but their surviving spouses. And Tiffany can talk about that here in a little bit. All the way into Medicaid, now starting to increase their rates across the United States, and even looking at new rules. We got this 80-20 rule that no one knows about. I'm not even going to get into that. That'll change 10 times over the next 4 years. All the way to private insurance with long-term care insurance, which have been around for many, many years, but Medicare Advantage, which Shane will briefly touch on. We are being talked about and put into plans that have been designated for healthcare providers for years, and now we're there. So I want to start there. Tiffany, can you talk about the VA benefits? What are the benefits? What's that process look like and journey for veterans to get their services on both the aid and attendance side and the hospital or the healthcare side? So I got something.
These are two very different programs. Now, when I was an owner, the only thing that was around was aids and attendance. And I feel like they used to make it really hard for veterans to get this service. You know, it's income based. There's a lot of holes that you have to jump through, and a lot of things that have to be in place. So now we have the community care based hours. And this comes directly from the VA. You have to be a provider. You get credentialed through TriWest or Optum, depending on what region you're in. Once that's complete, then you're now a VA provider. So as a home care agency, you can either A, get a referral from the VA case managers themselves, or you can go out in the community and start educating the veterans and the case managers on what this program looks like. And what I've learned is a lot of people don't know about it. It's not discussed. I'll go into a rehab center that has veterans that they're currently taking care of, and they've never heard about this. So now it's our job to come in and educate people on it. The cool thing is they really don't have to do much work. Once we do that, we can be the expert. We can come in and help them through the process, as we should. That is our job. And then we can tie in the aids and attendance. Now, aids and attendance, like I said, is a completely different program. The community care hours are needs-based. Aids and attendance is really income-based. You can have both, or you can have one or the other.
Awesome. Yeah. I mean, and let's talk about the Veterans Health Administration, just so people kind of have a picture of what that looks like. Years ago, there's billions of dollars that have been dedicated to community care through the VA, and I think the last statistic I heard, it was like 25% of that budget is being utilized. Sad picture. Yeah. There's so many veterans out there. We've been in multiple markets where the VA approves maybe 8 to. I'm not going to get into the whole political side on how people get approved for hours, but we do know that they're being withheld certain hours of needs that aren't having a massive impact. Where some veterans may need 20 to 30. I think that as long as we continue to voice our concerns to Congress, and I'm not going to get political today, that will start to increase to keep veterans safe at home. But years ago, when I first got on the VA, the rates were okay, right? And in my state, Nebraska, they were pretty good. But for the most part, it just wasn't a lot. So not a lot of people did it. And then this couple $1 billion budget came, and the system got flooded with providers. And now, Tiffany, I'm going to ask you about how we assist our franchise owners. Now you got to go through a credentialing process through TriWest or Optum. It's a long, grueling process. Can you kind of talk about how you've helped navigate owners through that process and what partners you may have used and what it looks like to become an accredited VA provider?
Yeah, so we partnered with, and I partnered with Paradigm prior to coming to a place at home. They are called Paradigm. They become the experts with the VA, within the VA system. They know the ins and outs, and there are certain areas that it is easier than others. They're going to be the ones that help us. They're going to be the ones that help push us through if there is a way to be pushed through at the time. Paradigm is a great resource, and they've been invaluable to both me at Nurse Next Door and now here being at a place at home. So that would be the place I would start. They also assist with billing. We're not the experts on that, nor should we be. Our focus should be on patient care. So we need to utilize the partnerships that we have with Paradigm and other resources. I know, and y'all can go into this in a little bit, Shane and Jennifer might hit on this. They also help with Medicaid and Medicare Advantage plans. But my focus is the VA. So they also have an education team. They help us learn how to market out there. We have Greg Bean, who has been invaluable to me as a coach. I learn from him constantly. And, it's nice to have people we can lean on for that.
Absolutely. So I want to talk, before I go on to Medicare Advantage plan, Shane, Jennifer, do you have anything to add about the VA? What are you seeing? How do you feel the VA's been with veterans care?
Shane, you want to start?
Go ahead, Jennifer.
Okay, so obviously Paradigm has been an amazing resource for us, helping us even on how to educate and market to veterans. I think it comes down to people don't know what they don't know, and they could even be in a senior living community and need veteran care and know that they don't know that they can get it for free. So it's our job now as providers to be that education. And yes, it is true. It's changed a little bit in some of our areas. We can't get veteran services right now. We can't get accredited. But that doesn't mean not ever. And some of our states are really, really strong with veteran care, and others we got aid in attendance. So we can still help with benefits, pension, and all that kind of stuff for families and give them respite care that's covered. But yeah, still huge supporter of VA. But I like to see a diverse payer source for franchisees. I don't think it's all one bucket. And I think if you put it all in one bucket, if one day veterans service is not allowed, then you don't have a business. So it's very, very smart to diversify. And it even helps us with referral sources, because when we go in and ask them, do you refer to home care? And they say, no, you guys are too expensive. Now we have something to tell them, and we can say, well, actually, we have a diverse payer source, and we can help long-term care, insurance. We can help with veterans. If maybe you have a bunch of veterans on inpatient, they don't know they can get services. So we have a leeway there to help. And then obviously Medicaid and Medicaid waiver, Medicaid Advantage plans that they don't know about. It's all about education and being the experts. And that's what I think our role is as providers.
Yeah. So let's talk. Oh, go ahead, Shane.
No, I was just going to say, to really emphasize what Jennifer just said there, you look at how far we've come as a industry. We were viewed as the redheaded stepchild, and we come into this marketplace, and it was one payer source. Now we've opened up, and all of us have such a heart for the vets and wanting to work with vets. And I remember getting into this, and it's a long, tedious paperwork that you'd have to go through with aid and tenants. Helps simplify some of those things, but still working with the VA and the red tape and trying to get services for our vets is still a very complicated process. And, you know, one of the dynamics that I love about this company, A Place at Home, is working with those vets. If we can have a better opportunity to serve them through what the VA is offering, expand, you know, the VA, if, you know, I'd love for them to hear this, they need to expand so that we can offer more services to those vets. And you see throughout the country, some are opening their purse strings, allowing other agencies to be part of that, where others, you know, California, even up in some of the eastern states, are still restricted. And then the lead time to get in and be approved is still a long, tedious process. But to everyone's point, to have an additional payer source, and especially those that have served our country, is very important for us to be able to provide them that service back to them.
Yeah, awesome. Well, thank you guys. I'm gonna keep it on a timeline here. So 12 years ago was what, 2012. There's VA benefits back then, and then this budget came, and then people weren't signing up for VA. And then all of a sudden, VA rates increased across the United States. And then everyone jumped on.
Yeah.
Right. And so I want to talk about, we're going to go to Medicaid, and we're going to end with Medicare Advantage, because we're going to go on to Medicaid. And my point is this: Medicaid is changing, right? We have the 80-20 rule that's coming out. Again, not going to go down in the weeds on that. But in most states, Tiffany, Texas, what's Medicaid's reimbursement?
I think it's like 18 or 19 an hour.
19 an hour. What's minimum wage?
Yeah, that's about the average hourly rate that we're paying CNAs now.
So there's not a lot of Medicaid services being done, especially by franchise brands that, you know, have a 5.5%, 5%, 6% royalty on top of it. Like, it just doesn't make sense. So the resources in Medicaid, on a lot of states, people aren't doing it, right? There are some states that are good, like Nebraska. Tennessee's pretty good. Oregon's pretty good, right? That we've seen our owners do. But the problem is this, is that with the VA, providers didn't do it. Now those that did do it back in the day, right, are reaping the benefits of that increase because they committed to the veterans years ago. Texas, you can't get credentialed right now. You can't take on veterans. You can't do it. We have franchise owners who have to give leads to other people in our system, which is fine because we want to take care of everybody. California can't do it anymore. It's shut down. It took us months on months in Arizona, and it's no fault. It's just they're saturated. The insurance company the Tri-West and Optum got flooded with providers. And my point is this: I'm of the belief that you should diversify and go into Medicaid, even if you get on and you don't take on a client. Now, some people say if you get on, you can't say no. I mean, there's ways to do that. But in addition, you're already credentialed. So when this does change to a positive, and I do believe, and maybe you guys disagree, Tiffany, Shane, and Jennifer, that you do believe that maybe it won't change for a long period of time. But I do see that they're going to have to put more resources and dollars into Medicaid at home. And what's going to happen is the rates are going to go up. They're going to be favorable. We're going to figure this 80-20. Their systems are going to get flooded with providers and shut it down again.
Yeah.
How do you guys feel about that, Jennifer? What have you seen?
Sure. Okay, so obviously prior to 1981, Medicaid waiver wasn't around. So it was putting people in nursing homes. And we know the trend right now is to keep people safe at home with dignity and as independent as possible. And we don't want to put people in nursing homes. My grandmother went into a nursing home. I have personal experience of what that was. And it wasn't a luxury nursing home. So, you know, the benefit of Medicaid waiver is to change the rules of Medicaid to allow more access to home care services, or even a bunch of things under the community model. That can be home improvements for aging. It can be transportation to medical appointments, what we call care coordination. But it gives people that ability to have a level of care at home and not be in a nursing home. But they have specifications. They have to qualify. First, they have to be Medicaid, and we know that that is the less disadvantaged population, the ones that are, around the poverty line. They're already getting no Medicare. So it's like that's a confusion too, because people think that home care is under Medicare, which it is not. It's under Medicaid waiver based on state, and each state has their own rules. And obviously this is senior focused for us, but it's also people with disabilities. It's children with disabilities. And we all want everybody to have universal health care, universal care when it comes to needs at home, and keeping that at home is our focus, our passion, what we want. And it should be something that should be entitled to most people, all people actually. And it's not, because the money's not there, but we know the aging population is happening. So putting people in nursing homes is not a solution. And I love that we're a solution-based organization. And there is lots of high needs that can be done in the home with the right solution and the right partnerships. And I think going forward in home care, in healthcare, and being a big player here is for us to continue to make strong partnerships and collaborate with people in the healthcare space, which we're already doing at A Place at Home. We have a few things up our sleeves, and we're looking at the bigger picture. We're innovative. We're moving ahead with technology. We're not afraid of technology, and that's a whole other discussion.
Did you say episode 2 technology?
I think we should. AI. I don't know.
All right. Well, no, thank you. So, Tiffany, Shane, anything to add on Medicaid waiver?
No, but Dustin, I never thought of, and as a coach, I'm not perfect. I'm being coached as I coach. I never thought of getting ahead of it, even if you don't like the rates, even if it's not really something that you want to concentrate on right now, going ahead and getting credentialed and having it in your back pocket just in case things change. I think that's super important. And I think that's
there's a level of regulation too. I would say you're going to be held to a standard. And that's another thing about like licensure, states that have licensure and states that don't have licensure. Some home care agency, some states like Nebraska, no licensure. I'm actually an advocate for licensure. I think it adds a barrier to entry so that, Joe Schmo can't just open up a home care and start putting bodies in somebody's home with zero knowledge of what it takes to take care of somebody just because you can bill it, right? So I think it's also good going on it because it'll keep you you'll keep your level of care higher because there's regulation you have to follow. Shane, do you have anything to add?
Well, it's to all your points. There's a level of integrity that as an agency we want to provide to our clients and future clients. And I'm very much a opponent of licensure. It brings accountability to the home care sphere. And to Tiffany's point, there's, when I started in this, it was private pay. We were looking at getting into the VA, and I would encourage broad and beyond that, look into the Medicare Advantage aspect of it so that we can have multiple sources, long-term insurance, VA, and now Medicare. So you're staying ahead of that tidal wave that's coming. And it's going to do the same thing that the VA has happened, where it blows up and they loosen, and then you have this flood to the marketplace again, and there's going to be a retraction, and then they're going to build it back up more. So I think getting into it in the very beginning is very key for any business owner.
Yeah. I'll give you an example. Nebraska's Medicaid rate went to I think it was 32, 33, right? And they got flooded. They got flooded. So much so that we were working with them, because I'm from Nebraska. We were trying to work. I was a board member on the Nebraska Home Care Association chapter. And I remember we were working on proposing some type of licensure. You know what they said? The state said, we don't have the resources to do that right now. They are overwhelmed with Medicaid, because once Medicaid's rates get to, then all these agencies, right? People would say we're a huge industry. I don't believe in market saturation. Market saturation to me is an excuse not to work hard. But we are very competitive. So once those rates go up and all of a sudden the 100 providers say, I want to get credentialed, you know how many people are doing the credentialing probably in that department? 1, 2 people, right? So why not start that process now and get ahead of it? You can always drop it, I mean, in the future. So those are 2
long process too.
It's a long process too.
For owners, it's complex, it's long, it's frustrating. There's tons of paperwork. So it's better to just get in now. And there's wait lists. So some states you can't even do it yet.
You have a good example in Louisiana. How long have they been doing it in Louisiana?
They haven't been able to serve Medicaid yet. They're still waiting.
Yeah, but how long have they? I think they've been waiting for a year.
Yeah. Oh yeah, over a year. Yeah.
So, anyways, I've seen it with many owners. I want to go on to bucket number 3, the ever emerging bucket that it's kind of confusing, but Shane has been doing his research on it. Medicare Advantage. All of a sudden, you guys remember that commercial that came out with, I think it's Joe Namath. Wasn't it Joe Namath? Remember that?
Yep.
He came out and he talked about how to get home care services through Medicare Advantage. Mr. Jets. I think this is the last time the Jets were any good. Not to put the Jets down on this, but not a very good program. They put Joe Namath out there talking about Medicare Advantage. And guess what happened? All of a sudden, these companies just start flooding. I know BrightStar. BrightStar was huge. Like, let's go do it. And it's like, well, how do you do it? Right? What's the reimbursement rate? What do you need? Do you need to be Medicare certified? What's this? What's that? And it's coming along. It's not quite there where I'm comfortable with it. And I know there's plans out there and there's people a lot smarter than me that are probably going through it. But Shane, tell me what your thoughts are on Medicare Advantage plans today and where you think they're going to go based off what you've seen.
Well, it's still a confusing paradigm right now. It's multiple choices. What used to be the Part A and Part B, and now they've added this Part C. Who knows? In the future, it could be Part D, Part E. But they're trying to make it more palatable for the home care agencies to jump into it more, given the ability for those that have these different plans to take advantage of who they want to take care of them. And that's really what it comes down to, is the benefits aspect of it. So A and B were kind of the original plans that were put in play, and not really strong plans, very limited. You were shackled by what you could or could not be able to receive. And then they came up with this Plan C, which, really the whole thing of insurance companies, they play with this, they add a little bit of this, and a lot of money in, and not much for choices that you can make. And I think that's what they were trying to do with Plan C, is to give a little more broader stroke of benefits. And so for the home care realm, again, it's going back to trying to jump onto this as another payer source, being able to offer another source to our clients. And it's still a very confusing marketplace. For those that are trying to get into it, they don't, even my visit with my dad this past weekend, talking about this very topic of how to get, which one to choose. What's the benefits look like for on that? And so I believe that we just, as time goes on, as these plans change, we have to be very innovative with our clients and how do we use those.
Well, and what they're doing is they're testing it out, because at the end of the day, they're spending money to try to save money in the long run. So, it's limited on what they're offering. And if you do become a provider, you need to do a good job, because you could either open up the door for us to be able to provide more care, or you could slam the door shut on us. Because if we're not preventing things from happening to save them money in the long run, they're not going to expand the program.
Yeah, you nailed it, Tiffany. That's what they're just beta testing this right now, to see how well it's going to do. And I mean, there are pockets where it's doing really well. And again, it goes back to state driven, back to agency driven. We're shackled. Some states are shackled more than others. But again, it comes right down to the very confusing process. And they they run with this, they're going to run with it for however long. Then it's going to get changed again, and then it's going to be new rules, new regulations, Plan D, whatever, and then it adds a little bit more benefits to that, and they'll beta test that for a few years and see if that runs out. So yeah, I mean, give and take. That's our government.
So let me give you guys some stats here. So here's where Medicare is going. According to debt.org, the average per day hospital cost in the United States is $2,883 per day.
Repeat that again, Dustin. The average
$2,883 per day. Now let's multiply that in a month. 2,883 times 30. That's $86,000 a month, right? Do you think that if they invested, if Medicare and these insurance companies started investing in preventative home care services, $100 a day, right? Now, how do you justify it, right? These are crises, and how do you qualify someone to get it? I think that they can do things like long-term care insurance does. You have to have comorbidities, right? You have to have some very high diagnoses, Parkinson's, fall risk, dementia, COPD, right? All those readmission factors, right? If they would just give preventative opportunities, which that's where these Medicare Advantage plans are going, they would save the hospital system and the healthcare system millions of dollars, and they're finally starting to see that. Do you guys agree with that?
Yeah.
Absolutely.
So I want to shift. Here's our buckets. We have private pay. That's where we were 12 years ago. That's all anyone went out. Home instead, that's all they did, right, Shane? They were the pioneers. They're 40, 50 years old now. I think they started in the late 80s. Is that right? Early 90s?
They're 31 years old.
31 years old. They're the pioneers. So this is still a relatively young industry in the grand scheme of things, right?
Yes.
But it started with private pay. We were sitters, companions. We didn't do anything medical. We were just babysitters. That went on for 25. Look how hyper growth this is, by the way. Yeah. That went on for 25, 30 years. And then 6-7 years ago, look at the impacts these things are doing. We need to penalize hospitals. People are going in and out of the hospital like crazy. They're readmitting for no reason. They're costing us millions of dollars. They finally did some research. And now all of a sudden, in the last 6 years, 25 years of private pay and long-term care insurance, right? 25 years. And in 6 years, they've increased Medicaid waiver rates in a lot of states. Not as many as there should. VA benefits are reasonable and now can give great access to care. Medicare Advantage plans are starting to come up, right? There's grants. There's all types of money that's going into the home care space. Now, that being said, I want to talk about the next phase. How does home care legitimize itself? Because we're still considered sitters, I think. I feel like we're starting to get away from what was the terminology, Jeff? Someone told you there's a new, what did Fatima out in Dublin said that they're getting away from the private duty, and what are we calling ourselves now, or home care is starting to say? You guys remember?
I don't.
Oh, I'm putting you guys on the spot.
I can't remember. Something with clinical?
No, it's something providers, but I forget what the...
in-home support services.
In-home support services, not companions, not sitters, not caregivers. In-home support services is starting. So now we've gone from a 30-year terminology of companions, sitters, and personal care attendants, whatever, to now in the last year, in-home support services, right? It's shifting that way. What do we have to do? And this is our vision as a place of home, and we're going to be an open book here for people who watch this. What are we going to do not as an agency, I'll tell you, but as an industry, what do we have to do to legitimize that? And I want your guys' opinion. I'm going to start is we have to start doing the things that healthcare providers have to do, right? There are people that I've seen schedule, and I don't think this happens anymore, schedule caregivers, do a care plan on a piece of paper, and then schedule someone on an Excel spreadsheet. That's like 1980s type scheduling. I still see people do it, right? You have to use an EMR system. You have to have a system that can communicate between you and the families, like a WellSky, right? We use WellSky as a whole, as an organization, but there's other ones out there. But within WellSky, then what do you got to do? That's a scheduling software, but now what do you got to do? You have to track your data and input changing conditions, hospitalizations, follow your patients, right? That's another thing I want to talk about. We call them clients. Everyone else calls them patients. So my question, should we be calling them patients? Should we be calling them patients? I don't know. I want to get some take on that later. Write that down, Jennifer. You're the best at memorizing.
All right. Yeah.
You're in Canada. Canada. They don't forget stuff in Canada, right?
Okay. Right.
All right. They're relaxed, eh?
We're relaxed, eh?
All right. But so one of our biggest directions with our company is using the WellSky's change in condition function, where caregivers are monitoring them and then saying, hey, not just tasks, right? You could put tasks in that they need a bath, they need help transferring and doing all these things. Now it's, hey, something's not right, right? Let me click on this button when I clock out, and I'm going to tell the home care, the in-home support services agency that something's going on. They're sleeping longer. They're more agitated than normal. Maybe they had dementia, right? That change of conditions fires off on us. Now, here's the key factor right here. Do you as an agency respond to that? Because I know dang well that if a home health company, a rehab center, and I'm going to pause and let one of you guys take this conversation further here in a second, a hospital, if they got an alert from some support staff in that hospital, that rehab, that home health, that hospice company, you bet your bottom dollar someone's butt would be on the line if an administrator didn't respond to that alert, correct? You guys agree with that?
Yeah, absolutely.
How many owners or how many agencies do you think, and I don't know, but trying to get people bought into that, what do you think what's the best practice for someone to do that? You see what I'm trying to say? Like, we have to be able to respond. What would be a good procedure? Tiffany, what's our procedure when we get that change in condition? Or Jennifer? Or Shay?
Well, I think you have to go further and train your office staff. So we have schedulers. I think schedulers' primary role has always been get a caregiver staffed in somebody's home, match a personality, and make sure there's never a shift that's missed. Now we're taking it a step further. What happens when the caregiver is there and we get this alert for a change of condition? What's the next step? Who do we call? Where do we go? Where do we triage this to? So I think that we have to do a good job of training our internal staff along with our field staff. And I think that's the next step in changing the course of how we handle change of conditions and how we fit into the care community.
Well, I think if we want to be a player with healthcare, this has to be something that is like a practice. If that alert happens, the owner has to get alerted. The home health, skilled nursing needs to be called in if there is a need for assessment. We don't want a rehospitalization at all costs. So if we train our caregivers enough to do the assessment for risk and change in condition, need a hospital, need a doctor, then that's where we start. But I mean, it goes further than that. We have to track these metrics as a company. And it has to be on like every month or every quarter. And it has to be, what is our company number? We want to be able to go into a facility and say, well, this is my number, but a place at home's risk number is this. Or rehospitalization is at 3%. What's yours? And I love when Shane talks about the data from WellSky, because he does real-time data. He brings in his laptop or whatever, and he shows them that we have data just like medical professionals. We're not medical professionals, but we're watching signs of illness. We're watching signs of decline in health. And if we can empower our teams to do this, then we're at a completely new level with home care.
I think you look at where we've come as an industry, and we put a plug in, and this could possibly be another segue for another show, but technology is going to be a very instrumental piece here. The major difference that we need to become as a home care agency is we got to be a subject matter expert. We have to, it goes as Tiffany's point, we have to train our team members to recognize and see when there is a change in care condition with our clients. Do we change the terminology from client to patient? I think we have to own the sphere that we're in, regardless of whatever the client is called, or a patient or resident, in whether it is, but we have to be viewed as a subject matter expert, whether it's Alzheimer's, whether it's end of life, as an end of life doula, whether our caregivers are coming in with that education, with that experience, to be able to identify things within the home or the community that they're working with that client or patient, to say there's something wrong here. And then there's a alert that is given within the office that we need a nurse involved to be able to look at where the change of condition needs to be. We own it on that level. Now the rest of the industry starts to look at us as experts in this field, not just a sitter, not just the mindset of, we're taking it from here, but taking it now to a level that is now more of an expert or a professional. We can use that term in the home care, home health sphere as well. So, and then also expanding the scope of services that we provide. We think through a lens of home care is X. And when I was with Home Instead, one of the things that I loved about the ingenuity that was coming about is looking beyond just the four walls of home care. Look at what we can now do, because states are pushing this. Florida is pushing it with ACA, that the nurse is more involved in oversight of care with those clients in the homes. Georgia, they're pushing regulations where the nurse becomes more of an oversight with those clients as well. And so we got to look beyond the lens of just providing a personal care into somebody and beyond private duty. Now it's looking beyond, how do we incentivize and train our caregivers so they become now the subject matter expert for pain management, medication reminders, because the old days of hand over hand and you're giving it to them is gone. And now there's more oversight in that. And it's great. I love it that the industry is evolving and changing, becoming more regulated. We as an industry now need to rise to that level and accept that responsibility. And technology is going to play into that. Looking beyond the sphere that we're in to a sphere now that grows within the industry. And we have to grow within and adapt.
Well, I think also we're improving outcomes. If we can show that, then we're doing quality of care. We're not just being sitters. We're not just doing personal care. We can have someone lying in bed and doesn't want to get up and eat breakfast or lunch and then watches TV all day. Or we can put in a professional caregiver that can get them going and do exercise and follow their PT and their OT and get them out for a walk and maybe have their family come and visit versus be a family caregiver. So we do have such an opening going into the future of what we could be for these families. And at the end of the day, we're improving care for the family, we're improving care for the senior and keeping them alive longer, but not just alive in a bed, but alive and to the best ability that we can and as independent as we can.
So you brought up something really interesting there, Jennifer, the term caregiver. I mean, this is an old term. You say I'm a caregiver, or you say the term caregiver. Everybody out there knows what that term is, but a lot of people also view caregiving at a certain level, like, it's a service working level. But the amount of time and of these caregivers are putting in for educating themselves, 40, 50 CU credits of training that they do, some of them spreading into being a CNA, and those aspirations even leading to be a nurse. This is the entry field for a lot of them, that they want to go into the healthcare profession and be a nurse or maybe even a doctor one day, because they see it on this very entry-level stage of providing that. Maybe the term that we need to use with our caregivers is care professional. they're a professional within the home health sphere that they're providing a service beyond just a sitter. They're now a subject matter expert, the time and energy and resources that we put behind them for them to be that expert in the field.
Shane, I love that because the term caregiver means you're giving the care. So it doesn't go beyond that.
Yeah.
Literally, it says
Care professionals. I really
care
like
professional means you're coordinating the care. You're looking for changes of condition. You're becoming more than just the giver of the care. You're becoming the expert of the care.
That's right.
So yeah, I love it too. And take it a little step further for you guys as well is now we've talked about the operational sense, right? How to do changing conditions, how to track your data, hospitalizations, fall prevention, like why you're there and when you're there. I bet you $10. It's really not our job. And that's the mindset that home care has right now. It's not our jobs to know what happens when we're not there. Well, guess what? If you can track when people have a fall, a hospitalization, when you're not there, you can put a value behind that, right? So to go back to that $86,000 a month, what's going on there?
No. Okay, are we still on?
I think we're still alive.
Okay, we'll continue the conversation.
Yeah.
Absolutely. I love that care professionals. I think that we would stand out. And I loved in-home support services, and we can start changing the terminology. I'd love to see us do even, activities within the home and some sort of curriculum to stand out.
Yeah, there's, I think it's very important that we change the perception of how home care has been viewed for so many years. And now we take the lead. It used to be like, Tiffany can allude to this, where we had the home care and the home health had to be in that same spirit to own both of it, but not anymore. You can be home care, have an expanded scope of services, be able to offer those services to our client, become the professional of choice. I want to be that, I don't like using the word vendor of choice. I want to be the professional of choice that's going to provide the professional care to those family members that are in need. And now you're thinking through the lens as
exactly
to those clients.
And a professional solution. We provide professional solutions based on our expert recommendations.
Yes.
And we look at data. We don't just give you a recommendation because we want a number of hours.
That's right.
Yeah, absolutely. I keep going back to thinking if we should call them client versus patient. And when I think patient, I think reactive. You become a patient because something has happened. I think that we should actually hold on to the term client because we're, almost a client navigator, navigating them through staying healthy, preventing things. Yep, that's kind of my take on it. Now, I also want to go back to titles, kind of what you said, Shane, instead of the caregiver. I used to get in trouble for saying caretaker when I first started because, I was told we're not taking care from them, we're giving them care. Now let's take it a step further. We're the care experts. I think titles do empower people, and I think we're now empowering these caregivers to take it a step further, and titles do matter at the end of the day.
Well, yes, we can hear you.
The government heard me talking about them paying $32 an hour, and look what happened. See that? I'm telling you, something is in my machine. I'm sorry that happened. We got like 6 minutes. Is that not a coincidence? Because I was going into what I would save Medicare, and I'm telling you, they said shut.
I know something happened there.
Shut this down. Well, I'm back. I'm not going to stand for it. And I'm going to tell you this real quick to elaborate. I said $86,000 a month in hospitalizations. Someone there's for 30 days based on averages on that website I mentioned earlier. It's not in front of me. But what if you did just 20 hours a week at a rate of $32 an hour as a preventative measure? 20 hours a week is a lot, probably be less than that. But and $32 is a good rate, but probably would be less than that if it's going to go through a government agency. Let's be honest, but be realistic, government, and pay us better because we're going to save you money. That's 40 clients for the same cost as one person in the hospital for 30 days. Now, I don't think the average hospital length of stay, and I don't have that in front of me, is 30 days. They want you in, they want you out, right? But
it's 3 days, 5 days on average. Yeah.
If they put money into, and I have other ideas, and this is another thing, ideas of what the insurance companies can do. Why not put a deductible, right? Why not put us in their annual deduct? People have $6,000, $12,000 deductibles. Why not put us on their deductible? Once you pay $12,000, your care is paid for after that.
It's coming.
You know what I mean? Like, all this is coming. It doesn't take rocket science to do this. However, it does take rocket science because the people. I'm gonna talk about this one. I'm spiraling right now because I got completely derailed, but. The people, this is why it's important to get a part of the HCOA and NAC and your government agencies and your lobbying agencies that are being funded by you, home care agencies in every single state. The reason being is that you guys all depend on everybody else to fight your battles for you in the home care space, when you, the agency owner, should be fighting your own battles and being part of the conversation when these policies are being made, because the people making these policy, I'm going to be honest, don't know their head from their ass. So I'm just going to be real. They don't. We're
going to lose those connections.
Huh? I'm going to get cut off again. Watch. So I'm serious, though. We've come a long way, right? But it's on us agencies to do these. Let's recap it. To do these things. Track your data. Show your outcomes, show your customer service scores and how you impact their lives, not just by their health, but their mental psyche, right? We've made them happier, right? Track those things, take those things to your hospitals, to your advocacy agencies, the HCOAs, go to your congressmen and women and say, here's what I've done. Here's what you want to talk about a Medicare insurance problem 20 years from now, you dillweeds. Here you go. Here's what you do. And if the home care agencies in this country, and there's a lot of them, combine forces to do that, right? Oh, we got Kansas City. We got Brad posting the stats. Overall hospital readmissions cost Medicare over $26 billion annually. Thank you, Brad. See?
Brad will be featured next month.
What's that?
I said Brad is our featured owner next month.
Yeah.
Did you know that, Brad?
But that's the thing, and that's what Place at Home, and especially Shane and Tiffany and Jennifer and myself are going to do, is we got to fight. It's not going to be easy. There's going to be bureaucrats. There's going to be people with a lot more money than us who are fighting against and saying, "Oh, we want people in the hospitals. That's how we get paid." It's a fact. It's a political game, right, Shane?
Yes, it is. Yeah.
Right.
Yeah.
Play the politics. But you can't just talk about it. You have to show your data to prove it.
Yeah.
And so with a couple minutes, I want to go around and say, what's one thing that a home care agency can do to better our industry in the healthcare space? Are you ready? I'm going to go last because I want you guys to take the good ones and leave me with nothing, and I'll just think of something. All right. Ready? Tiffany, you're first.
I think my focus with my owners is creating better plans of care, understanding maybe the top 3 diseases or the top 3 clients, what they look like in their profiles, and making sure we're training our internal staff and our direct staff on what to look for in changes of condition based on those top 3.
That's great. So care plan innovation. You're absolutely right. That's a thing that we're working on, that you raised your hand and volunteered so greatly to do, is work on developing stronger care plans, not just from a personal body, but from a holistic approach, you said, right? So can't wait to see what you come up with on that. Shane, what's one thing that we can improve upon?
So we need to be more subject matter experts in this field. It will align itself with being innovative in our assessments and our care plans, and it will be viewed as someone who is the professional in that home care space.
Absolutely. Learn your stuff, know what you're doing. You're not a sitter company. You're not a staffing agency anymore. We used to be a staffing agency. I mean, I'm not going to lie. I was 28, had zero idea what I was doing. I just put bodies in homes and hoped it worked out. Not going to lie. Right? I didn't know how to do a care plan. But it's evolved. It's evolved because we are getting more medical necessary. Jennifer, you.
To have all our owners really focus on key tracking metrics, including the lifetime of a client. I think that's a really important metric we have to watch. But rehospitalizations and the improving of outcomes, that proves what home care does. And we have to do that in our marketing. We have to do that when we talk in the field. We have to do that when we're talking to referral sources. And we have to know, just like Shane said, we're experts now.
Exactly. All right. Closing thought from me on this is I'll take all three care plans, subject matter experts, use your data, and then use that to create strong relationships with those that are above. And what I mean by those that are above is home care is either a preventative service or home care is the last line of services. We're either the beginning or we're towards the end, and you have home health, hospitals, post-acute, and rehabs all in the middle. We're on the front end and the back end. We're not in the middle, right? We're not in the hospital. We can go in the hospital with them, but usually we're not. You have to use that data to talk to those individuals because that is the standard that they're held to as organizations. Data, outcomes, and satisfaction of their patients. That is the data metrics that they're held accountable for. You have to be held accountable for those as well and show them that you're holding yourselves accountable to it.
That's right.
That's it.
Yeah. All right.
I want to thank you guys all. That was a good one, right?
Yeah,
Our first episode. That was a tough one too, but we're going to do more. We'll come out with new topics in the future. Thank you guys all for being here. Peace out.
All right. Bye-bye.